Well, I've been invited to be on this panel to bring kind of the international part of things, but I want to preface it with something because you two went first. I think my international experience inspired me to come home and provide services in places like the Family Health Center. So I did work for 15 years in a federally qualified health center as well, not in Kalamazoo County, but near here. So I just wanted to bring that up because I think that my experiences working in Guatemala and in Mexico were the impetus for me to work in that type of setting as well. So with that said, I want to explain a little bit of what I did in Guatemala and Mexico, and bring just that background to it so that we can have a jumping off place for questions. So first of all, I worked with Guatemalan refugees in Mexico, and then I worked with them again when they returned to Guatemala. So to understand why I had to work there with them, or why I was working there with them, you have to understand a little bit of the history. At first I thought I wasn't going to talk very much about that history, because it was a little outside of the scope, I thought, of what the panel was about. And then I read the book. Okay, so I kind of agreed to do the panel before I read the book. And when I read The Strength in What Remains, I recognized the similarities of the work I had done and what Tracy Kidder talks about with Dale's story. So I want to give that background. The Guatemalans, when I worked with them in the early 1990s, were already organized in refugee camps in Mexico. And I could go back to the Spanish conquest in 1524 to explain how they got where they are and what happened there. It's a fairly typical story in Latin American countries, I think, about the violence and instability and how things are dealt with, etc. So I won't go into all that history. I'll just tell you about the thing that made them come to Mexico. So in 1982, as part of the government's war with the guerrilla insurgency, which kind of represented the poor people, so it was definitely a poverty-induced issue here. It was the poor against the rich in Guatemala, and the government represented the rich. So in 1982, as trying to suppress the guerrilla insurgency in the Ixcan area of Guatemala, they had a scorched earth campaign, basically. So the military went into the Ixcan. They burned 440 villages. There's different estimates because there's so many mass graves that they found, but there was conservative estimates are about 50,000 people were massacred. And I mean massacred. I mean, these are stories like in Strength in What Remains. I mean, they are really horrendous to listen to and really hard, really difficult. And so I was reminded of them as I read this book. So they came into Mexico. And then there's that story of hope and help that was available to them. And as they came into Mexico, those 200,000 people fled across the border. About 46,000 of them ended up in refugee camps. The rest kind of dispersed in Mexico and were welcomed and got help and got what they needed. I always wondered, would that have been so welcoming in our country? You know, if there was a massacre in southern Canada or northern Mexico, and we had 200,000 people come across the borders seeking refuge, would we be that welcoming? Well, Mexico they were very welcoming. So, but eventually they started organizing those camps. So when I got there, they'd already been at it for a good 8-9 years of organizing and taking advantage of help from non-governmental organizations, the United Nations, from the Mexican government, from the Catholic Church, from other church groups. Lots of international non-governmental organizations participated in helping them to organize. The political part of that was organizing to return to Mexico. But the real parts started way before they ever came over, trying to organize themselves to fight for their human rights and non-discrimination ages. And so that was a big part of what they were doing. So their organization included community service. Guess what? Everyone in the community was assigned community service. So everybody in those camps that were part of the communities that they broke down had to provide service to the people that they lived with. So if they didn't volunteer, sometimes they were assigned, and I'm not very happy about it. But they might be assigned to be a dental health promoter, or a medical health promoter, public health promoter, education promoter, mental health promoters they had. They had people who were assigned to just work on organizing their return. So all kinds of developmental projects came out of that. They took advantage of any kind of training they could get. So that's where I kind of slipped in. So in the early 90s when I was there was a lot of public health projects already going on, latrine building and protecting water supply and that type of thing, basic hygiene. But there wasn't anyone really training people to provide medical services. So that's, I set up a program in the 4 camps in Campeche and worked with training health promoters in basic diagnosis and treatment. And they also acted as a preceptor for those health promoters in helping them do home visits and working in their little makeshift clinics that they had sometimes. So that's what I did. And I, when I was asked to, after I read the book and was asked to come on this panel, I recognized that when we were talking here about the blend of international and poverty right here at home in Michigan, it really becomes political and it becomes personal. Okay, so that's why the kind of take-home message is that, you know, when the political becomes personal, everybody gets involved. You know, so if it's happening to you or happening to someone you know and care about, then you want to be involved. And so that's a really, I think, an important thing. And if we want to really address, if we are really passionate about taking care of people and people in poverty, then we have to get a little political. Anyway, with that said, sorry, I went on. I always do that.
My name is Bill Walker, and I'm a pathologist at Brownson Hospital. And when Dr. Long asked me to be on the panel, he was a little wary about, you know, use pathology. Why would a pathologist be involved with this? Well, first I want to tell you that pathology that you see on CSI and the other television shows, it's not really what 99% of pathologists do. We're certainly trained in that area, but that kind of pathology specialists, pathologists like myself, primarily are focused in the laboratory, and we spend almost all of our time behind the microscope looking at biopsies or anything else that any doctor takes off of or out of any patient. So anytime you go to a dermatologist, get something shaved off your skin, or anytime a surgeon biopsies anything, it comes to the pathologists for interpretation, and that diagnosis is then used to treat patients. And I sort of also have an international perspective here because I've had a great interest in international medical missions for about 10 years now. I spend a fair amount of time overseas each year working in smaller hospitals in countries in Africa, Eastern Europe, I've been to China. But most of my work is through a nonprofit organization called International Pathology Services, and I actually look at biopsy specimens from small missions hospitals all around the world that are sent to me here, and then I evaluate the specimen and make diagnoses, and then through email and whatnot, reports get back to missions hospitals, probably in about 35 or 40 different countries around the world. And so that's my connection with international medicine. I have worked in several hospitals overseas in Africa. While I haven't been to Deo's clinic in Burundi, I have a really good idea what it must be like from time that I've spent in other African hospitals, and what the kind of medical care that the poor people there receive versus what we're used to receiving here, or even what some of the poor patients here receive, is absolutely amazing. The hospitals that I've worked in, when the doors open in the morning for the clinics, hundreds of people are lined up before the clinics open. These patients some of them have walked for days, if not weeks, to get to these hospitals, because once you get outside the big cities, there aren't that many quality hospitals or clinics around. So, for example, when I worked in a small hospital in Kenya, patients will come from Ethiopia and Somalia, they'll walk for days and days because they know they can get quality care at this one hospital. So they'll line up. If they need to be admitted to the hospital, their families will oftentimes bring them food, do all the personal care for them while they're in the hospital. They don't have very many nurses, they don't have food services, so families rally around and support family members that are in the hospital. Costs are kept down as much as possible, but it's still very expensive for a vast majority of these patients. If they're making, in Kenya, on the average of $3, $4, $5 American dollars a month, well, then any charge in the hospital is going to be huge. And so what I found is the docs that are there are very attuned as to keeping costs down, unlike docs here in the States. So tests are only ordered when they're absolutely necessary. The docs there are very good at physical exam and making diagnoses without all the testing that we have available to us here, like CAT scans and MRIs and whatnot. So I really admire many of the physicians that are there, you know, their diagnostic skills. I know that Tracy Kidder, when he was talking last week at the event, mentioned that sometimes patients are almost kept prisoner after they're done with their hospital stay because they have to pay their bill before they leave. Well, that sometimes does happen. What I found happens oftentimes is families have to rally around, pool their financial resources, they pitch in for their relative can be discharged. So the family unit is very strong in many of these smaller African countries. And it's actually sort of refreshing to see that. So that's my perspective. I do much of my work here, but I interact with docs all around the world on a daily basis. Just this morning, for example, I was looking at biopsy cases from Cameroon, Papua New Guinea, and so I'm interacting through email with docs all around the world on a daily basis. It's just sort of an introduction to who I am and what I do.